So to answer this question, we really need to think about how this is being done today. And today, radiologists and surgeons use CTs and MRIs, which are all black and white images that are slices of your body, slices of your head or of your chest. And each slice represents an intersection, and it is a grayscale image. Radiologists scroll through these and they try to understand the differences between the slices. They look for different subtleties and changes between one slice to the next to detect the tumor. That is unlikely to change in the near future. However, what is important is that this data is already 3D data, technically. They're just looking at it in intersection in 2D ways. So what you can do is you can take this content and render it volumetrically. You take all the slices, you stack them like a cube, and then you render that, and you have raw data rendering that can be very useful for other use cases, such as procedure planning. Surgeons really like this kind of content because they don't have to look at black and white 2D slices anymore. They get a much better insight in what is going on with the patient's body he has. You can also use this for education purposes, for example. So this is something that you see happening now. This content is being represented more and more in 3D for other use cases than radiologists, because obviously not everybody is a radiologist. The one thing that's important in the future is that these visualizations, to be successful in clinical and healthcare environments, is workflow. They really need to be integrated in existing workflows. And that means that a clinician, be it a surgeon, for example, they have very little time and are always doing something. You don't want to interrupt this. So the device that you use to bring these experiences to the clinicians has to be capable to do both of these things. And that's where 2D and 3D switching is very important. So the solution that we've worked on with you is 3D switching is a key differentiator of the product, because the surgeon can be doing the planning of his OR for that day. He can also be doing his mail, or for all I know, he could be reading a news in a break. Once he wants to do his 3D imaging and wants to do his prep, he presses the 3D button in his software and everything swaps automatically. And that really is the enabler for this adoption, for this technology to know a lot of adoption. And that's probably where we're going. We will still always have the 2D scans, like the way that MRIs and CTs have acquisition, that will not change. But it is important to realize that the way you present this data to users enables new workflows, and it becomes more efficient and it becomes faster, and surgeons can be more confident in what they are doing. That's really where I see it going. So there are a few challenges that drive the need for this technology, and the summary is it's about depth. Depth is very important in medical imaging. As I said in my previous question, the scans are slices and you stack them into a cube, and then you basically have a representation of the body of a human. That's a challenge when you want to prepare your surgery, for example. When you prepare your surgery, let's take a liver resection, for example. You want to resect the liver, but you do not want to do any damage to any of the veins that you don't need to, or you do not want to puncture the stomach while you're going to it. For a surgeon to really understand that well, they need depth information. They want to make a mental map of where they're going and where they need to be. Depth you can only provide with some kind of stereoscopic technology. You also want it to be easy to use and quick to use. And that's where the immersive technology comes in. Because with classic solutions, such as headset solutions, you have to put it on, you have to launch the application. That all deducts from the experience, and they have to deal with things they don't really have time for. With the immersive technology, you can integrate it very nicely into a viewer that runs as a normal application on a computer. But when you need to get this information, you click your 3D button in your viewer and everything happens automatically. You're looking at a real-time render. In a second, you have a 3D image pop out, and you can do that prep. You can make that mental image without sacrificing anything else in your workflow. And that's where the key differentiator comes in. I think this question is great, but it's also a bit limiting, because when it comes to clinical imaging, the root of the content is always 3D. The CTs and the MRIs, okay, they're flat slices, but you can always stack all the slices and you have your representation of your body. So it is always 3D content. So in that way, where it has the biggest impact is a tough decision to make. Where I think it will be most difficult for this technology to know adoption is diagnosis. Let's get that out of the way. Radiologists are very trained in the current way that they read these slices and that they scroll through them to look for differences. That is not going away anytime soon. However, for all the other uses that you can think of, such as the ones you have here, planning and patient communication, and you could also think of education, for example, the benefit that representing this content in 3D in a very easy fashion is priceless. So where is the impact biggest? It depends on what you're looking at. For planning, for example, you're creating a better prepared surgeon. A better prepared surgeon will have less doubts about what he's doing. He will make less mistakes, and hence the patient outcomes will be better. For patient communication, for example, showing the patient 3D images instead of black and white slices that they barely understand, that will only lead to a patient better understanding what's wrong with him and what's going to happen with him. And you can think of other cases as well in clinical imaging. Education, for example, is a very important one. It's not only to teach people anatomy, teaching them that in 3D is helpful, but you can also create simulators of real procedures that again will give a surgeon a better insight in what they will have to do later, but you can also train them quicker and more efficient. So in my perspective, anywhere where you have 3D content that's starting to pop up, you will have quite a big impact in clinical imaging. I really think 3D in healthcare is the future of clinical imaging. The fact that we've now managed to make the first display, Aeronis 3D, that has this capability means that we have to start finding where it sticks. And we have a few use cases where we're slowly getting adoption. And that also means that more and more clinical people will get to see the capability of this, and it will be a snowball effect. So we're starting with a use case where everything makes 100% sense and we 100% know we will be successful. And from there, we can scale to more and more challenging use cases where the requirements are much more difficult. And that means that there is a good chance that in a few years, let's not say how many, there is a good chance that every display that will be used in a medical environment will have this kind of technology on board, because that really is the ambition. I've talked a lot about the CTs and the MRIs so far, but that's not the only 3D content out there. You also have the 3D that's coming out of endoscopes and out of robotic surgery that can also help during operations, for example. It's a much more challenging use case from a technology perspective, but once the technology has been proven to be usable, you can scale to these kinds of use cases as well, and that's very valuable. It's actually a key point of success for this kind of technology, because clinicians in general are very busy and they like to play with new technology, but it has to work. If you introduce something that they have to play with and it only works half the time, or there is a steep learning curve, then it will not get used. And unfortunately, from experience, we know that VR and AR, while very cool and it works well in workshop kind of environments, it has struggled to really know adoption in these healthcare environments. And that's because it doesn't integrate well in existing workflows. It really takes time and effort to set it up properly. And that's not something that the Ionis 3D that we implemented has right now. You can have it in your desk or in the consultation room or on the side at an OR to consult images like you would have any normal display. and that makes it very easy to use. It also means that you don't necessarily have to change the way they are working. All you need is a good integration with the software viewer that presents the data to the end user in an intuitive way. So that way, what they have always been doing and what they know doesn't really change that much. And that's very critical for them because, again, the workflows are regulated and they also just have very little time. With regulated workflows, that means that it takes time to completely implement new things. But if you fit in the normal workflow very well, you reduce the barrier there. And because these people have little time, if you don't have to teach them something new, that again reduces the barrier. So the timing works quite well right now because you see a lot of other things moving right now. You see that there is more and more 3D content being available. So you see more and more companies working on segmentations of existing scans. You also see more and more 3D being used in the operating rooms in the shape of robotics and laparoscopic surgeries where stereo endoscopes are being used. And it's also a point where the technology has reached a maturity where it can really stick with the user. And it's a bit of a summary of the questions we just had. But the fact that the workflow is as easy as it is to use right now makes it a very intuitive and interesting value proposition. You can just have it on your desk. You don't need to do anything else. When you click your 3D button, it just works, so to speak, in a very Apple way. But that means that we have reached a point where we believe the time is right to introduce it into healthcare environments and that we can be successful with it. Everybody who sees what the AONIS 3D can do together with the software from our partner at our medical says it's amazing. And it really is. The real-time rendering that provides presents you with, in essence, what's nearly a hologram of the scan that you're looking at. And there is not much out there right now that can give a similar experience to that. So the amount of insight and depth that you perceive from this compared to classical solution is unmatched today. So nearly every surgeon we've talked to loves it. Nearly every patient that has gotten something explained to it loved it. We're working on some studies that are yet to come out, but the feedback has been across the board very positive. So that has been amazing. So now we've launched the first product, and for us, this really is a first attempt at immersive visualization and seeing how we have to scale this up actively. But we can already see the signs that a lot of people are asking for this and they want to use this. This really is the next step or the next generation in clinical visualization. So without a doubt, we are looking at a roadmap to expand from the first use case we have to more use cases, to go to class 2 medical devices as well, and go from there. Where exactly we will land, I don't know yet. It will depend a little bit on the success we have with this first product, but without a doubt, Barco will build a roadmap based on 3D technology.